On behalf of Boulder Community Health, it's my pleasure to introduce this evening's speaker, Nathan Susnow. Dr. Susnow is a board-certified and fellowship-trained gastroenterologist with additional expertise in complex liver disease. Dr. Susnow has been practicing in the greater Boulder, Denver area since 2016. He sees patients at Gastroenterology of the Rockies in Boulder, Lafayette, and Longmont. Welcome, Dr. Susnow.
Hello, thanks, Karen. So I am here to talk about colon cancer and help everybody to understand kind of how it develops and also how we can detect it and in some cases prevent it. And additionally, talking about some groups that are higher risk for colon cancer and how to identify yourself potentially if you may be in one of those groups. So a little bit about me. I originally went to college at Rice University in Houston, Texas, back in 1996 to 2000. Subsequently medical school at UT Southwestern in Dallas. I did kind of started with my GI interest there and focused on cancer pathways in another condition, Barrett's esophagus, which can lead to esophageal cancer. Subsequently, came out here for residency at the University of Colorado and did a research elective focusing on NSAIDs, which is aspirin, ibuprofen, a number of others, and their effects on colon cancer risk, which we'll briefly touch on in a bit. And then went out to University of Washington for my GI fellowship. I did more research in cancer development at a cellular level there, and also researched hepatitis C and risk factors for recurrence after liver transplant. And then I subsequently did a one-year fellowship at Northwestern, kind of focused on liver transplant and complex liver care. After that, I don't have it on my slides, but I worked in Madison for about 3 years, and then I actually came out here in about 2014 and have been in the Boulder area since then. So March is Colon Cancer Awareness Month, and that's one of the reasons we do this presentation typically in March. In 2000, it was Bill Clinton who officially dedicated March as National Colorectal Cancer Awareness Month. In 2019, Governor Polis signed a proclamation in Colorado declaring it as Colon Cancer Awareness Month. And if you're in Denver, sometimes you can see that the building can be lit up in blue parts of this month, and always something fun to see. Colon cancer is common, and you read about it sometimes in the news, and I have a few people listed on my slides here that have had colon cancer. I added a couple this year, unfortunately. I think last year I added Chadwick Boseman, who was quite young when he was diagnosed, Kirstie Alley, Pele also with colon cancer, and then our others here, President Ronald Reagan, Justice Ginsburg, Pope John Paul II, Daryl Strawberry at a young age also, and a few others. Jay Monahan, who's Katie Couric's husband, who passed away from, I think it was actually squamous cell cancer, Charles Schultz, and a number of other people. So this is a common condition that if you kind of watch out for it, you hear about friends of friends having it, sometimes friends or family members, and see it in the news occasionally. Colon cancer is the result of a sequence of events, and again, common. It is lethal if not detected and treated, and it is actually preventable, which is a rare thing with cancers. A lot of cancer screening that we all undergo is generally focused on finding cancers, and with colon cancer, we actually can prevent it a large amount of the time. So as we kind of work our way through here, we'll talk about what colon cancer is, and to start with that, we want to understand what the colon is. So here's a diagram of the colon. It's about 5 feet long. We divide it in gastroenterology into segments so that we can kind of define where things are. The very top is called the cecum, and then as you work your way down, so the cecum is where the small intestine empties into the colon, and as things come down, you go through the ascending colon, the transverse colon, the descending colon, the sigmoid colon, which kind of makes an S turn, and then the rectum is at the very bottom, and then out comes the poop. With colon cancer, it can present in various ways. It can have no symptoms, but it can also have things that you'd want to watch for and talk to your doctor if you have any of these. And these are things like blood in the stool, a change in your bowel habits. So maybe you used to go once a day and now you're going every 3 days. Changes in the shape or the size of the stool, noticing that it's thin or it's changed in some way. Pain, so pain that's particularly like rectal pain or abdominal pain that's new, unexplained weight loss, and sometimes anemia are all ways that colon cancer can prevent or can present. With colonoscopy, basically we can put a camera through your bottom and into the colon, and we can look for any abnormalities. So we can look for colon cancer and then precursors to colon cancer, which are called polyps. And so if you see here, this is a picture of a relatively small colon cancer, and you can see it's just kind of this ugly bleeding thing that's sitting on the side of the colon wall there. And then here's a picture of a polyp and another polyp, and then a really large polyp. And all of these are things that we're looking for when we're in the colon, because these are problems that can develop and cause issues. So colon cancers originally generally arise from what are called adenomatous polyps. And these polyps start out really small, and that's kind of on the left side of the slide here with just this what is labeled as hyperproliferation. And over time with genetic mutations, they grow and get larger, and as they get larger, they have more mutations, and eventually they can develop cancer within the polyp. You can see on the slide here that we talk about benign and malignant. And so when a cancer develops inside of the polyp, that can still be benign in the sense that it's still treatable and removable with colonoscopy, but once it's invaded into deeper tissues, which is shown here where it says adenocarcinoma and has that kind of white cancer tissue coming into that lower layer, at that point it's what we would call a malignancy or a cancer that needs to be surgically removed and may need additional treatments. Most polyps do not become cancerous. So when we look in people's colons, we find lots of polyps, and we don't really know how to predict, with the small ones at least, which ones will eventually turn into a cancer. Almost all colon cancers do come from polyps though. So by removing small polyps and large polyps, we can prevent them from progressing to colon cancer. It takes a long time for a polyp to go from very, very small into a cancer, overall around 10 years. So when we think about screening intervals for colon cancer, generally we do a colonoscopy every 10 years in somebody who has no polyps, with the overall thought there being, and the research supporting it, that it takes about 10 years to go from kind of nothing or a minuscule non-visible polyp into cancer. And so we're trying to catch things relatively early. In terms of different types of polyps, I wanted to show some additional pictures here in terms of things that we encounter in the colon. And so the figure 1 hyperplastic polyp is actually a type of polyp that's not precancerous. We generally don't know that just looking at it with our cameras. And so we remove all polyps, and then we find out from our pathologists when they look under the microscope, or what you could call biopsy them essentially, to find out what type of polyp they are. Figure 2 notes a tubular adenoma, which are viewed as precancerous, and then other types of adenomas are shown here too. The picture on the right is with a specific type of imaging called narrowband imaging that we use sometimes to better highlight polyp tissue when the margins are not well defined. And you can see a few of those here, with polyps being anything from these big kind of bumpy things that stick out to very flat and fairly subtle lesions that we want to remove, and we want to identify the entire lesion and take it out. Follow-up with colonoscopy is often determined by what type of polyp you have and how easy or simple it is to remove and how large it is. And then here's a couple pictures of colon cancer. So one on the left that's kind of taking up about half of the colon wall, and then one on the right that we would call nearly circumferential, or kind of coming all the way around, and what we call a traditional apple core type lesion, which is how they are often seen on CAT scans. So colon cancer is common. It's one of the frequent cancers that are encountered in the United States. There are lots of cases of colon cancer, and you can see here with breast, lung, and prostate, they kind of make up the majority of cancers that we see. In Colorado, similar kind of rates, a little bit lower with colon cancer, but this is a common cancer. Globally, it's the second most common cancer in women and third most common in men, and fourth leading cause of cancer overall. about 150,000 Americans are diagnosed with colon cancer annually, and about 50,000 Americans overall die from colon cancer annually. And so it's about 8% of cancer deaths that we see. Importantly, colon cancer is preventable. So as we were showing with colonoscopy, we can go in with our scopes, take out polyps, and by doing that, we can actually prevent most colon cancers. In terms of looking at incidence rates of colon cancer, this has been kind of a tale of good and bad. So on the plus side, for those 50 and older, we've seen big decreases in rates of colon cancer over the years, and it's dropped quite a bit, 40% since 1987. And a big part of this is thought to be better screening modalities with colonoscopy. On the other hand, there has been an increase in cancers in younger age groups, so in basically under the age of 50. And this is what's led to a push that you might have heard about, which is that colon cancer screening has changed from age 50 down to age 45 when we start screening now. And so we started at an earlier age because the rate we're seeing at 45 years old is similar to what we saw in the past at 50. It's thought that this uptick may be related to less healthy diets overall, more processed foods, and then also to more sedentary and less active lifestyles, although it's not completely worked out at this point. So a risk factor is really anything that can change your risk for getting a disease such as cancer. Different cancers can have different risk factors, and having a risk factor doesn't necessarily mean that you're going to get that disease, but it does indicate that it may be more likely than it otherwise would be. So for colon cancer, we know a large number of risk factors. Country of origin, interestingly enough, is a risk factor. Hungary has the highest risk for colon cancer. If that ever comes up on Jeopardy or anything, you'll know the answer now. Age can be a risk. Obviously, as we get older, the risk for colon cancer does tend to go up. Men are at higher risk for colon cancer than women, although lifetime risk overall is the same because women tend to live a little bit longer, which makes up for that difference from a cancer risk standpoint. Race is a risk factor for colon cancer. African Americans have generally had a higher risk for colon cancer than other races. Diet, which we will talk about in a little bit, and then family history. And out of all of these, family history is really the biggest risk that you can have for colon cancer, and something that you'd want to talk to your doctor about if you have family members who have been affected by colon cancer. And that includes rectal cancer, I should say, which are kind of an overlap, but essentially similar from a risk perspective. So when we look at family history and colorectal cancer risk, lifetime risk overall about 5% for developing colon cancer. As you have more relatives or relatives affected at a younger age, these risks really increase a lot. And so you can see here that one first-degree relative, about a twofold risk, 2.5. Less than 50, it goes up quite a bit. 2 first-degree relatives kind of stays at that elevated rate, and then 2 or more first-degree relatives, or what we call Lynch syndrome, which is a genetic syndrome that predisposes to colon cancer, the risks really jump dramatically. And so we will screen patients more frequently if they have a family history that's significant for colon cancer, depending on that risk. So other risk factors also exist for colon cancer, and these include lifestyle. So that includes being overweight, obesity, lower levels of physical activity, smoking, and alcohol, and then dietary choices too. So diets that are high in red and processed meats, low fiber diets, not eating a lot of fruits and vegetables, eating a lot of charred and broiled and grilled foods can actually increase the risk. And what that relates to is that char on the food, which seems to be kind of an oxidant and can cause cancers in the colon, and then ultra-processed foods. And so number kind of the biggest risk factor though, overall, failure to get screened. So we can adjust these risks by screening patients for colon cancer. And just to mention with ultra-processed foods, what these kind of refer to is a lot of the stuff in the middle of the grocery store. When you look at the ingredient label and it has a bunch of chemicals that you wouldn't have in your pantry, those are generally ultra-processed foods. If it has ingredients that you recognize, flour, salt, sugar, etc., that's processed, but not at the same risk category as ultra-processed. So as we discussed, multiple Americans every year will get colon cancer and die from colon cancer. And so we need to talk about kind of how we look at that and how we address it. Staging is something that's done once you're diagnosed with colon cancer. Obviously, we want to find ideally polyps and remove them and prevent colon cancer. But additionally, the earlier we can find it, the easier it is to treat and the more likely we are to be successful treating colon cancer. So ideally, we are finding it in those early stages, stage 1 and 2, before it's begun to spread outside of the colon. Stage 3 is kind of once it's moved into the local tissues, and stage 4 is when it's gone to other organs. And stage 4 colon cancer, even with modern therapies that our oncologists have available, is still quite deadly, with 5-year survivals overall less than 5%. And you can see here, survival very good with stage 1 and 2, and really improving. There's been a lot of acceleration of treatments in the oncology space, but still finding cancer early makes it much, much more treatable. So early detection overall is critical to finding colon cancer and treating it. And then just looking at these risk factors again, the focus for most of us is on lifestyle and diet if we want to modify our risks. We can't really affect our age, our sex, our ethnicity, our family history, but you can do things in terms of the choices you make with what you eat, what you do with yourself to affect those risks, and also recognizing when you might benefit from screening. So, in general, in terms of prevention, we do know that being overweight and not being physically active are both linked to colon cancer risk. And I always encourage my patients to work on being active and view that as a separate modifiable risk factor from weight loss. Often we can get frustrated when we exercise and we aren't losing weight, and you really need to view that as a separate and successful intervention. Diets that are high in red meat, and that includes basically any mammal, so beef, pork, lamb, and also liver if you like liver, can increase the risk for colon cancer. And additionally, processed foods, so hot dogs and lunch meats, can raise your cancer risk. So in general, what's kind of the lowest risk diet for colon cancer? Plant-based Mediterranean type diet is going to have the lowest risk. Smoking is a significant risk for colon cancer and does increase the risk. And then additionally, moderate to heavy alcohol use, so in the range of about 3+ drinks a night, is going to increase your risk significantly for colon cancer. There are protective factors, and so I think it's important to mention aspirin. Aspirin does lower the risk for colon cancer. It has been looked at as a preventative for people to take. The downside of aspirin is it can increase the risk of certain types of bleeding, like strokes, ulcers in the stomach, and so the evidence has generally not shown that the benefits outweigh the risks of aspirin therapy in most patients. For selected patients who are very high risk, there does seem to be some benefit to taking aspirin. It may outweigh the risks depending on your lifestyle and what you do. If you live in Boulder and you ski and do those sort of things, aspirin maybe isn't the best choice unless you have other reasons to take it. But it's always something good to talk about potentially. We're going to go through some of the screening modalities that we use to check for colon polyps and cancer, and what their various effectiveness is, particularly in terms of how early can they find things and intervene. And so when we think about this, stool tests, which are available for colon cancer screening, generally detect cancer, and to some extent large polyps. And really their main thing they detect is cancer. They do not generally detect small polyps, which makes it a little more complicated on the colonoscopy side to remove. And then additionally, there's imaging and then colonoscopy. So by looking, we can potentially find smaller polyps. And there's 2 ways to image the colon that we'll talk about. In terms of the stool tests that are used, there's 2 main ones out there. So there's what's called FIT testing. It used to be called FOBT, fecal immunochemical testing. That looks for blood in the stool. As polyps become very large and then turn into cancer, they often will have small amounts of blood that you may not see, but can be detectable with testing. And so if those are positive, generally the next step is to get a colonoscopy so that we can look and try to see if there's a source of blood. With The Cologuard-based testing, it looks for blood and cancer DNA. And so again, kind of looking for a cancer, looking for something advanced. And most importantly, when you do this test, you have to recognize that if it's positive, you got to follow up and come see us and get a colonoscopy. Doing the test and not following up when it's positive has not really done you any favors. With the FIT testing, generally, it's actually 3 samples that are recommended, so you don't just do one. And then as we talked about with the Cologuard, it's the poop in a box test that gets advertised. So you poop into a little container, mail that in, and they're going to check for blood and cancer DNA. When you look at these non-invasive assessments for cancer or cancer DNA and blood in the stool, these generally are not great at detecting larger polyps. Again, they do detect some. So if they're negative, which means nothing was detected, no blood, no cancer DNA, versus positive, with positive tests, they can detect about 30, in Cologuard's case, about 30 to 40% of large polyps, and with FIT testing, about 25%. Which I think for most of us isn't quite ideal when colonoscopy is in kind of the 95 to 100% range, but it's still far better than nothing, and it's important with these tests to do them regularly as recommended. When we look at Cologuard specifically, it finds colon cancer about 92% of the time, which is pretty good for detecting colon cancer. FIT testing a little lower, 75 to 80%, and then colonoscopy, which is viewed as the gold standard, 95%. Again, those larger polyps drops pretty dramatically in terms of the effectiveness of non-invasive tests, 42 and 30 to 40%. And then false positives. I have seen the stress that comes with false positives, in particular Cologuards. There's kind of a time delay there. You get your positive Cologuard, you schedule your colonoscopy for a week, 2 weeks, 3 weeks later, and you're worried the whole time. Most of the time, a positive Cologuard does not have colon cancer. So if you do Cologuard or a FIT test and it's positive, get your colonoscopy, but you don't need to be sitting on pins and needles. The majority of the time it's a false positive, but sometimes it does detect things that are important. And then these false negatives, these do miss colon cancers, unfortunately. So with colonoscopy, generally that is the gold standard that we have. It is more involved than these tests, so that's kind of the downside. And if you're busy and you don't have time, doing something's always better than nothing. With colonoscopy, we have to look, and to look, you need to be clean. So we have you drink a bowel prep, which is kind of a laxative prep that you're going to take the day before and sometimes the morning of if it's an afternoon procedure. That's going to clear you out. You're going to go to the bathroom 5 to 10 times, kind of depending on the person and how things go through, and wash everything through so that you're nice and clean, and then we can go in with the scope while you're sleepy and take a look. Generally, what we do with the scope is we kind of insert it into your bottom and we work our way up to the top of the colon, and then we slowly pull the scope out and look for polyps or anything else that's abnormal. With doing that procedure, most people prefer to be sedated. It's kind of moderately uncomfortable as we push the scope through. And then as we come out, there's really no discomfort, but at that point, usually the sedatives are on board and you're taking a nap. When you wake up afterwards, usually the main sensation is that you're a little gassy because we inflate your colon with air, but otherwise don't necessarily know that the exam was even done. Additionally, we can use CT colonography, which is not as common nowadays. And here's a picture of kind of that colonoscope working its way up through the colon, and then they're taking out a polyp. So that's kind of the snare sitting over to the left and then the polyp on the right, and we can open that snare a little more, put it around the polyp, and then cut underneath it. CT colonography was the other thing I was getting to. So this sounds kind of nice. It's a CAT scan that looks at the colon. It does have a few drawbacks. It is a decent test to screen for colon cancer. But it still involves a bowel prep. So to see well, you generally still have to drink a bowel prep and wash things out. You still have to inflate the colon with air. So you got to come into the radiology suite and have your colon inflated with air. And then you have a CAT scan, which does involve some radiation. Additionally, in terms of making this a kind of cost-effective test, the American College for Radiology is recommended that polyps that are 6 millimeters or small don't necessarily have to be followed up with a colonoscopy to remove them. Most of us in GI would very much prefer to remove small polyps rather than large polyps. As polyps get larger, the risk for complications with removal goes up. And so My general advice is if you do a CT colonography and you have any polyps, I would go get a colonoscopy. But for most people, doing either one of the stool-based tests or getting a colonoscopy usually makes more sense from kind of an involvement and time perspective. And that's kind of been what's taken over. With colonoscopy, quality is very important. So we really want to get a good prep. A lot of patients will ask, why'd you make me do the dose in the middle of the night? Like, why'd I have to get up and drink it? I could have drank it all the night before. And that's actually really important to cleaning out the right side of the colon. So we call that a split dose prep. You generally drink half the night before, and then you drink half the prep 4 or 5 hours before your exam, which sometimes if you're early morning means you're getting up really early, 2 or 3 a.m. to drink that second half of the prep. Even though you're not eating, bile, other things, kind of cells are turning over in your bowel, and it kind of gets, and there's mucus too, and things get a little bit dirty on the right side up at the top of the colon. So we want that prep relatively close to the exam, so it's kind of like you just came through the car wash and now you're coming in and we're getting a good look while things are clean. And this is kind of an example up here of excellent prep, good prep, fair prep, and poor prep. Fair and poor preps generally mean you have an unsuccessful exam. So if we put the scope in and we're seeing things that we can't clear out easily, poop or stool, or even just liquid that's too thick, then we're going to say we didn't get a good enough exam and we got to do more prep or figure out another way to do this. If you have constipation, it's always good to treat that in advance of drinking the prep. Important to discuss with the scheduler or making an appointment to come in and talk to one of us in the office if you're concerned that you may have challenges or need some modifications to what we normally do. And then just reading the instructions carefully in advance. We generally have you eat a low-fiber diet for a few days beforehand. And so if you're just reading them the night before, you might miss some of these things that can really help to have a great prep. Colonoscopy, number one, as we kind of discussed, it is by far the most effective colon cancer prevention test. It detects 3 times more of advanced lesions than FIT testing and 2 times more than the FIT DNA, which is the Cologuard. Advanced lesions are kind of the main ones we worry about. So these are polyps that have reached the point where they are quite large. They have genetic changes in them that indicate these are likely to become colon cancer with time, if not already. Additionally, it kind of takes advantage of that it's a single test. You don't have to do something and then come in for something else. We take care of everything at the same time. Your risk stratified, and then we know when you need to come back. And if it's normal, you're a very low risk for colon cancer and can come back at 10-year intervals. There's many studies out there looking at different ways to approach colonoscopy. Even just doing one colonoscopy is very effective for your overall long-term colon cancer risk. If you come in and say, I'm only going to do this once, and it's normal, your lifetime risk for colon cancer is lower than it otherwise would be. Risks of colonoscopy, so that's something we often worry about as well. I'm going to come in, I'm going to have a procedure, what's the risk of having a complication? In general, extremely small. So cardiopulmonary risks, so that's things like breathing issues or heart irregularities during the exam, very rare. Overall quoted is less than 1%. We see these almost never. If you have certain risk factors, we might need to change how we do the procedure and sometimes discuss the safety, but for most people, this is a very safe procedure. Perforation risk is kind of the big thing we worry about, or you know somebody who knows somebody who had a perforation. This is exceedingly rare. There have been studies of tens of thousands of patients that have found perforation with screening colonoscopy is in the 0.03 to 0.07% risk. In general, 1 in 2,000 is sort of considered acceptable standard of care. I like to put my own data up here. So in 13 years now of doing GI, almost 14, at about 1,000 colonoscopies per year, I've had 1 perforation that was not in a screening exam and 1 perforation that was delayed after cutting out a fairly large polyp. And so I can't say that the risk is 0, but I can say that it's fairly small. Bleeding after polyp removal is a risk, overall about 0.5 percentage point. I think every single bleed I have seen from polyp removal is with removal of large polyps. So small polyps we don't get too worried about. As something gets bigger that we have to cut out, there's more blood that flows to that lesion, and so more risk afterwards. And that's something your doctor would talk to you about if you removed it. Of course, the benefit is higher too with removing large polyps. Death attributable to colonoscopy, overall in the population, 1 in 15,000. I don't have any deaths that I can attribute to colonoscopy in my personal patient population, and hope to get through my career without any. Lifetime odds of death, so just to kind of give you a comparison, your chance of dying in a motor vehicle accident, about 1% lifetime, a fall, about 1%, being shot, 1 in 200, drowning, 1 in 1,000. So much lower in general than other risks we experience in day-to-day life. Not quite zero, but I think small. And what the studies would say is you're more likely to benefit from getting a colonoscopy than to be harmed by quite a large amount. Quality of colonoscopy is very important. Generally, I think all gastroenterologists should be expected now to use high-definition colonoscopes. Any colonoscope that's been made in the last probably 5 to 8 years would be high def. Just like TVs improved a lot 20 years ago, colonoscopes did too. And you saw those pictures earlier of these flat, very subtle lesions. With good equipment, we can find these much more effectively. You want a careful exam of the entire colon. The data that's out there generally says that the GI doc should be spending at least 6 minutes pulling the scope out and looking for polyps. So that's after getting to the top of the colon. For most of us, at least at GI of the Rockies, we are more in about the 10-minute range for a normal colonoscopy where we're just looking and not having to remove anything. Experienced endoscopists are going to have much better outcomes than inexperienced. In general, we look at cecal intubation rate, so that means did you get to the top of the colon, and that should be expected to be over 95%. And adenoma detection rate, which overall, on the lower limit of kind of what's acceptable, we would expect in women to find at least 20% of women, we'd find at least one adenomatous polyp. Those are the precancerous type polyps, and at least over 30% in men. Average in the US is around 40% or 39% overall. My metrics from the last year, we just got our new ones, but it was too late for me to put them in the presentation. My withdrawal time overall was 10 minutes. My adenoma detection rate in men, 65. It was 63 on our last 12 months, so I went down by 2%, but I would view that as within the margin of error. And then in females, 52%, and then on this last one, I was 51. And cecal intubation rates, which in our group we don't really monitor because we're all well over 95%, generally in the 98 to 100% range. There is a study that came out a couple years ago that I at least wanted to touch on. It was called the Nordic study, and it was in the news a little bit. This was a study in the Scandinavian countries, Norway, Poland, Sweden, and the Netherlands, which looked at one colonoscopy versus no screening. It was not necessarily the way we would do it in the US. It was randomized from the population. So it was not randomized from the primary care doctor or an advertisement. It was a random letter sent to patients that invited them to get a colonoscopy, and the primary endpoints they looked at were colon cancer incidence and mortality after 10 to 15 years. So they kind of sent the letters, watched people, and then once those 15 years for the earliest patients had passed and 10 years for the latest patients in the study, they looked at cancer incidence and mortality. One important thing to note is the endoscopists in these countries overall had very poor polyp detection rates. So we talked about that ADR rate earlier, and their rates were less than 25%, which at least in our practice at the GI of the Rockies would really be an unacceptable rate of polyp detection. It's an indicator that the look that doctor is getting is maybe not as good as they should. Again, average in the US is 40% overall. The risk of colon cancer was 18% lower in the group invited to undergo screening, so it did appear to lower their risk. They did not see a decreased risk of death overall, and it raises the question, is colonoscopy effective? Is this doing a good job? The problem is the design of the study and how it worked. So they sent this single letter to patients, and actually somewhat impressively, 42% followed up on that letter and went and got a colonoscopy, which I think is actually impressive with one letter you received in the mail. And then everybody was included in the outcome analysis. So whether somebody got a colonoscopy or not, they got put into that group. Of the 60% who didn't get one, they're all in the group of colonoscopy. Of those who had a colonoscopy, 31% reduced colon cancer risk, 50% reduced risk of death. The average follow-up was short. We talked about that 10-year interval from polyps to cancer. And so generally, we kind of think about removing these small polyps as preventing cancer 10, 15 years, maybe 20 or 30 years down the road, kind of depending on the random rate of mutations that occurs in those polyps. For those who had it, it obviously worked very well. At GI of the Rockies, we were actually the first in Colorado to incorporate GI Genius. This is a technology from Medtronic, which is essentially a local company. To some extent, they have a big office here, that improved adenoma detection rate, so that's that ability to detect polyps, and cancer detection, 13%. They looked at the combination of those. Generally, I think what they were really seeing was polyp detection rates. And what it is it's a little system that kind of puts a box around what the computer that's helping you views as a polyp. And so you can see in these trials, 42 up to 55% for adenoma detection rates. We do find it helpful. We use it in all of our centers, and we're I think the only ones in Colorado that actually do that. And it kind of, to some extent is like a little kid that sits there and points at stuff and wants you to go take a second look, but it's helpful. It sometimes can find fairly subtle lesions that we might not have otherwise identified, and we have seen increased detection rates within our practice. Overall, looking at risk and when we should screen patients, most importantly, we look for average, well, not most importantly, but we look for what risk are you and when do you need to come in. So average risk, no personal history of colon cancer or polyps, and no family history. And then additionally, IBD here is inflammatory bowel disease. So Crohn's and ulcerative colitis, which if you have a history of that, can increase cancer risk and generally can indicate that we have to do somewhat more frequent screening. We start at age 45. We stop somewhere in 75 to 85 range. That depends on overall health. We kind of look at colonoscopy as most helpful for patients who have about a 10-year life expectancy or more. So as you get into your 70s and 80s, it's always kind of a question to ask your doctor of how healthy am I? How long do we think I have? It's very hard to predict that, but looking at overall health also predicts how well you can tolerate something like a colonoscopy. And doing another test like these stool-based tests, you always have to think if it's positive, am I going to do a colonoscopy? If the answer is no, don't do the test because it's just going to add stress. Options for screening, the frequency that we screen depends on the test. So the FIT testing, which is a stool test for blood, is recommended annually. It's hard to comply with that for a lot of patients, but that's kind of what's out there for it to be effective. The FIT DNA test, which is Cologuard, is every 3 years. Flexible sigmoidoscopy every 5 years. It's really not done much anymore. It's kind of a lot of the work of the colonoscopy without looking at the whole colon. CT colonography every 5 years, again, also not done as often anymore because of the involvement in doing that and subsequently needing a colonoscopy. And then colonoscopy every 10 years with a normal exam. If screening is done, overall colorectal cancer cases and deaths decrease by about 60 to 80%. So screening guidelines that are out there, there's multiple kind of large agencies that make recommendations. The U.S. Preventative Services Task Force in 2016 had recommended colorectal cancer screening starting at age 50, continuing until 75, and noting there was multiple screening strategies to choose from, and then to individualize screening in terms of what you want to do in that 76 to 85 range, and recommendation to stop after that. However, we know that cancer risks, and we talked about this earlier, have been rising in younger age groups. And so in 2017, we saw that these studies kept showing that cancer is going up in the young. And in general, if we lowered the screening age to 45, we could decrease new colon cancers by 4 to 8%. And that's primarily by going and taking out polyps before they turn into cancer, and decreasing colon cancer deaths 8 to 11%. With some increase in colonoscopies, right? If you check everybody 45 to 50, you're going to do a lot more colonoscopies. But on the big benefit there is really reducing colon cancer impact. And so a couple years ago, guidelines were changed, and the recommendation was to start screening at age 45, again continuing to 75, and then individualize at 76 to 85. American Cancer Society agrees. They recommend at age 45 that you start colon cancer screening. And additionally, in Colorado, House Bill 20-1103 passed in 2020 that required insurance companies to cover colon cancer screening at 45 and above, so that it couldn't be denied below age 50. Looking at patients at increased risk, so first-degree relatives of patients with colorectal cancer, we do start sooner. So if you have a mom or dad or brother or sister affected by colon cancer, we generally will start screening at age 40, sometimes earlier. We really want to look at what age Was that relative? And always thinking about how to screen. Additionally, in increased risk groups, the recommendations are pretty clear that colonoscopy is what you need. The less effective screening modalities become far less effective when your risk for colon cancer goes up. And then hereditary syndromes. There are certain genetic syndromes that increase the risk quite a bit for colon cancer, and then screening starts quite a bit earlier, often in teens and 20s, kind of depending. So looking at family history and the increased risk, the risk goes up as you get older regardless, but with family history, you're always going to sit at a higher risk than you would be otherwise. On average, patients with a family member with a history of colon cancer develop cancer about 10 years earlier, and so that's why we start screening a little bit earlier too. There are some familial syndromes that can cause colon cancer, or what we call hereditary causes of colon cancer. So these are genetic syndromes that are passed between family members, so passed down from your parents potentially, sometimes de novo also, that can increase the risk for colon cancer. The vast majority of colon cancers are sporadic, so I think it's always important to recognize you have no family history, you have no increased risk, you're actually in the majority of colon cancers that we see. The syndromes increase the risk quite a bit, but these syndromes are relatively uncommon. One that we see pretty frequently is called Lynch syndrome, or HNPCC, was a different nomenclature for it. And that's a syndrome that significantly increases the risk for colon cancer and has genetic testing that can look for it. There's another syndrome called familial adenomatous polyposis, or FAP. This is more treated in the pediatric population because they get innumerable colon polyps and generally present at a younger age. But we do see both in the adult population. With Lynch syndrome, it's autosomal dominant, so that means that you don't need both parents to have the mutation to get it, you just need one. It's about 3% of colon cancers, and the risk is quite high. It can be up to 50% depending on your mutation, and it presents earlier. So early onset, often at around 44 years average, often can be high up in the colon, so more proximal, and associated with other cancers. So this is a syndrome that is generally monitored both with colonoscopy and additional tests to look for other types of cancers that can develop. It is testable with gene testing that's relatively inexpensive and available, and the screening is quite effective. We do a lot of colonoscopies on these patients, generally every 1 to 2 years, starting at a relatively young age. FAP, or familial adenomatous polyposis, is rare. Also what we call autosomal dominant, so again, only needs one mom or dad to pass it down to you. Very high risk, essentially 100% for colon cancer. It is fairly easy to recognize. You can see this picture here. This is a colonoscopy, and this is the scope kind of turned backwards looking out, and just innumerable polyps here. So many, I don't know that you could remove these with the colonoscopy unless you were willing to spend days doing it. And so these patients get very frequent surveillance and generally will have to have their colon removed at a fairly young age because we don't have a way to prevent a colon cancer from forming. So looking at colon cancer and kind of summarizing, colon cancer is the 4th most common cancer in the US and the 2nd most common cause of cancer death in the US. The best screening test is one you get done, because we know that cancer is a kind of slow progression from those small polyps into large polyps to cancer, and it can be lethal. So doing things that you can do in terms of modifiable risk factors is important, and then screening is really important both to risk stratify, find out what your risk is, because what we see is a really good marker of your overall risk for colon cancer, but getting some screening done and then recognizing if you have a family history and talking to your doctor about that. In terms of take-home points, colonoscopy is preventative. We can prevent colon cancer with this test. If you don't have any increased risk, we start at age 45. It is the only test recommended if you have a strong family history for colon cancer, particularly in first-degree relatives. It's every 10 years if it's normal. If we find and remove polyps, it's sooner, kind of depending on what's found. For most patients, 1 or 2 small polyps, you will come back a little bit earlier, 5 to 7 years. And then with higher risk, larger polyps, more polyps, you can be coming back in 3 years or sometimes sooner, although that is much less common. Always important to touch base with your doctor if you think you have any increased risk for colon cancer. If you don't want to do a colonoscopy, get something done. So FIT test yearly, that's that stool test for blood, or the Cologuard every 3 years. Both can be effective. They're not perfect, but they will find at least cancer once it develops in most cases, and are still going to lower your risk of dying from colon cancer. So I think that summarizes my talk, and I'm happy to take any questions that are out there.
Thank you, Doctor. That was very informational. Appreciate that, and want to remind our audience that now is the time to put your general question in the chat box below the video. We have had several questions coming in, and just we'll start going through that in no particular order.
All right.
Is diverticulitis a precursor to cancer?
Yeah, so good question. So diverticulosis, which is the presence of kind of small pockets that we can see fairly commonly in the colon, is something we see a lot of. Diverticulitis is a complication of diverticulosis and is an infection within those pockets that often presents with a fair amount of pain, fevers and chills, often something that you're not going to ride out and you're going to end up seeing a doctor going to the ER for. Diverticulitis does not increase the risk for colon cancer. Generally speaking, guidelines that are out there would say if you have a single episode of diverticulitis, a first episode, you should have a colonoscopy. We know in studies that CAT scans and presentations of colon cancer and diverticulitis can overlap. And so somebody who presents with diverticulitis is recommended to have a follow-up colonoscopy to confirm that there is no cancer, that there is no abnormality in that area, and that this was just what we would call run-of-the-mill diverticulitis. But if, say, you have diverticulitis, you recover, we do the colonoscopy a few weeks later, everything looks good, I see that diverticulosis, but no cancer, no colitis, or what we call Crohn's or ulcerative colitis, then I would tell you to come back in 10 years. Your risk would not be increased. But important to get a look after that first episode.
Okay. Are screenings always necessary after age 71? What is that name? The age range where you have the counsel with your doctor as far as the when you stop it?
Yeah, so generally screening is recommended up to age 75, fairly clearly, just based on kind of overall life expectancy and health within the US. 75 to 85 is where we would say conversation with your doctor. And so some of that is based on findings too with colonoscopy, if you have colonoscopies. You know, if we know that you're somebody who's had higher risk polyps or lots of polyps, or somebody with a first degree relative with colon cancer and you're in relatively good health, we may screen you up until 85, sometimes even a little bit later than that if your health is really good. It also depends on how easy the colonoscopy is to perform and how you do with sedation and anesthesia as you get older. So it gets a little bit complicated in that age range. It's always a good discussion with your primary care doctor or a good discussion with the gastroenterologist in the office.
This person is 61. Their father had colon cancer, but passed from pancreatic cancer. BRCA testing identified APC gene. How often should I get a colonoscopy?
I guess it would depend on the specific APC gene mutation, and I guess I'm not sure if they had it or their dad had it, but that would generally be at least every 5 years. As we talked about with the hereditary syndromes, it could be more frequent than that. The APC is a polyposis type gene, and there can be some more uncommon mutations within that gene that can lead to more specific recommendations for testing. But I guess I would say no less often than every 5 years, and it may be more frequent than that.
So someone had a polyp the first time they had a colonoscopy. They were 62, and it was a tubular adenoma. They wanted you to describe what that means, and then also how often they should repeat the colonoscopy with that type.
So a tubular adenoma is kind of that lower risk precancerous type polyp. So essentially an early polyp, but they are precancerous. We remove those during colonoscopy. And then when you come back, it depends on a few factors. So the size, most polyps that we would remove are going to be under 1 centimeter in diameter, which for us is kind of the cutoff of where we view a polyp as higher risk, more along that progression to cancer. So one small tubular adenoma less than 1 centimeter. Current guidelines say that's a 7-year follow-up. There's a different type of adenoma called a sessile serrated adenoma that we follow up a little sooner in 5 years when they're small. And then if that next exam is normal, you actually go back to every 10 years if you have no increased risk. It's a little bit different. The guidelines have changed over the years. 10, 15 years ago, we basically said, oh, you had a tubular adenoma, you got to come every 5 years forever. Now what we know is if you have a tubular adenoma, you come back in about 7 years, sometimes 5, and you don't have one, your risk is essentially the same as if you never had any. So we're kind of looking for, are you still growing more polyps, or did you have that one and we removed it and everything looks good?
Okay. Very helpful. Thank you. What do you do if you cannot tolerate the prep?
Well, there's a lot of different preps out there, so it kind of depends on what the challenge is with the prep. Sometimes for patients that have constipation, one of the things is getting ahead of it, taking some laxatives in advance of the prep so that you're not kind of completely full and then adding more into your colon. For other patients, it's issues with nausea and vomiting and just difficulty tolerating it and getting it all down, and then you can really slow it down. We can prescribe medications in advance to help with any nausea. But often it's not a bad idea to think about, oh, I tried it, I made the appointment, I tried to do it, it didn't happen. Come see us in the office and talk to us about what happened and how we can potentially plan for that and get it done. And then sometimes when patients come in, they follow all the directions. They're like, I didn't think I had constipation. I did everything you told me, and I'm not clear, right? Or maybe we put the scope in and we say you're not clear. And then really it's a question of, okay, can we do more prep and bring you back tomorrow, or are we going to reschedule and have you do something additional beforehand? Generally, if a patient comes in and we look and they're not clean enough, we will always try to accommodate getting it done the next day if you want to come back. We don't like people to have to leave and then reschedule and start from zero when they're halfway there when they come in.
But there is a way to counter the nausea?
There's medications we can use, and then additionally sometimes kind of slowing down how quickly you drink it. Generally, people get our instructions and it says to drink 8 ounces every 15 minutes to get through the first 32 ounces. And the most common thing I hear from patients is kind of they're trying to keep up with that schedule while they're getting nauseous. And what I would say is if you get nauseous, just stop, take a break, wait for 30 minutes or an hour until things are kind of moving through, and stop very early on when you get nauseous. Don't try to keep pushing into your stomach. For a lot of people, though, if they do throw up, which is uncommon, they actually still, a lot of the prep gets through. It often ends up being kind of stomach content, stomach acid that you throw up, and you still end up going to the bathroom and clearing out. But my one piece of advice would be don't push it. If you get nauseous, slow down, give us a call if you need some help, but give things some time to start moving through before you drink more.
Very helpful. Thank you. So you offer colonoscopy without sedation. Can you talk about that a little bit more?
Yeah, we do. So I probably do an unsedated colonoscopy once every other week or so. If a patient doesn't want sedation, that is certainly their choice. Colonoscopy, I would say, is not like surgery. It's uncomfortable. There's kind of some deep-seated abdominal pain with it, kind of like a lot of pressure, and then some gas discomfort too, because we're blowing your colon up with air. Most patients that don't want sedation do great. They get through it. They'll often tell us there is some pain and discomfort, but they kind of take deep breaths and hang in there and do okay. The uncomfortable part for most people is anywhere from 3 or 4 minutes to about 10 or 20 minutes, just depending how easy it is to get to the top of their colon. As we take the scope out, the discomfort really is almost gone because you're just kind of slowly pulling the scope out, not pushing it in anymore. I would say most people prefer to be sedated. It's not comfortable. It's nice if you can just take a nap. The sedatives that we use are generally mild and well tolerated, but enough that you sleep and don't have to kind of get that pain and discomfort with the exam. But an unsedated colonoscopy is always an option.
Kind of on the flip side, can you ask for full sedation, or does the doctor sometimes recommend full sedation?
Yeah, I mean, we do different types of anesthesia depending on what you need. We want to plan that in advance, but we often do conscious sedation, which for most people it's called conscious, but the vast majority of people take a nap and don't remember. But they are arousable in the sense that if I tap you on the shoulder and ask you to ask how you're feeling, you'll kind of wake up and tell me and go back to sleep. And then we also do deeper sedation, monitored anesthesia care, propofol-based sedation that is much deeper, and you do sleep. We still generally are going to have you breathing. It is very rare that we do a colonoscopy with a breathing tube in, so it's not quite the same as a surgery general anesthesia. But for most people with both of those sedations, it goes well, and you take a nap during the exam.
Okay, thank you. This person had a biopsy. They had hyperplastic polyp and a mucosal lymphoid aggregate. How many years do they need to wait?
So mucosal lymphoid aggregates are benign. That's kind of a little bump we see. We call it a polyp because we're just looking with the scope. We say there's a polyp, we take it out. Pathologist says it's a lymphoid aggregate, and that is a nothing. It's not a polyp. It's just kind of a natural little bump related to the immune system and harmless to remove, but also not likely or impossible for it to do anything else. It's just going to be there forever until we remove it, and it's not an issue. Hyperplastic polyps in general are not precancerous, so most hyperplastic polyps, it's a 10-year follow-up. If they are 1 centimeter or over, then we do view those as higher risk, and we bring you back sooner. Vast majority of hyperplastic polyps are down in the lower part of the colon, the sigmoid or the rectum, sometimes the descending, and don't require any earlier follow-up.
Okay. You talked a little bit about Colorado passing that insurance has to cover if you are 45 and need or want a colonoscopy. Can you talk just in more general about insurance cost coverage for these tests and procedures, please?
Yeah, so it's been a, I guess, changing landscape is how I would call it. Insurance has been a challenge over the years for a couple reasons. One, historically with the other tests, if you went and did a Cologuard or a stool test for blood, and it was positive, they would say you had your screening test, now you're having a diagnostic exam, and therefore it's not covered under your screening benefit. That has changed. And there's been kind of a push from guidelines to say, the screening is a 2-step test. You did the first test, it was positive, and you need to do the second part of the screening. That has improved. I can't say that I'm a lawyer, so I cannot say that I know for 100% of insurances it is covered. It's always a good question to ask. So that's number one. Two is what we had an issue with historically was you came in for a screening colonoscopy, we removed a polyp. Now the polyp's been removed, and the insurance company would say that wasn't screening, that was diagnostic. That has generally gone away. So as far as I'm aware, we are not having issues with insurance covering your colonoscopy as a screening exam if you come in for screening. It can be something we have to work out if there's a history of polyps. So depending on insurances, they will still sometimes say, well, you have a history of polyps, you're not an average or screening anymore, that's a follow-up or a surveillance exam, and depending on your specific plan, there can be costs associated. It is always covered, assuming your doctor's doing it appropriately, the exam's covered through all of these scenarios, but it's a question of whether it's under a screening benefit or whether it's what's viewed as diagnostic, which would be the same as, say, you have to get your gallbladder out, you have your deductible and all of that. Screening coverage is supposed to be 100%, no copay, no deductible, completely covered. And again, that generally is the case now for average risk screening, but can still be a challenge for a history of polyps having to come in sooner for a follow-up exam, although it is slowly moving the right direction.
Okay. We're going to squeeze in just a couple more questions here, just real quickly. How do you know if you need to have gene testing?
So I guess I would say you would know that if you have a family history of colon cancer. First thing to do would be to talk to your primary care doctor. You can also just look online in terms of my, blankety blank family member. My dad and my aunt on my dad's side had colon cancer. Do I need testing? And then for some of those patients, particularly if you have more than one relative affected or a relative who was affected at a young age, you may benefit from gene testing. And there's an easy website you can go to, find a genetic counselor. I think it's findageneticcounselor.org, which can help you find a genetic counselor who can kind of fully assess your history in terms of your family history and determine whether you should have testing and what testing you benefit from.
And is that covered by insurance?
It is covered by insurance. Additionally, what I would say is if you have a family member affected by colon cancer currently, I think everybody pretty much is doing this. I know that we do. If we diagnose a colon cancer, there is an automatic testing on those biopsies that occurs to check for those genetic mutations in that cancer. And so we can identify if somebody comes in and they're 60 and they're having screening and they have a colon cancer, we can generally identify if they would benefit from additional genetic testing or not based on the results of the cancer tissue we test.
And then what if a person has had multiple colonoscopies with polyps found every time? Would you lean towards them having gene testing as well?
If we find enough polyps, so generally kind of in that 1 to 3 or 4 polyp range on a number of colonoscopies doesn't necessarily put you into a category where we need to test for genetic causes. Over 10 or so tubular adenomas can indicate an increased risk to some extent. And so some of those patients who have had lots of polyps can benefit from gene testing.
And last question, we've heard of testing going earlier. Now it's at 45. If you have a family history and so you're the first removed, what about for the kids? Should they start even earlier, and what age is recommended?
So what we call, second degree relatives, so a grandchild, or a grandparent had colon cancer, generally earlier screening isn't recommended. So the risk is fairly small because this doesn't tend to skip generations. So first degree relative, mom, dad, brothers, sisters, what we generally say is you start at 40 or 10 years before the relative was diagnosed. So if you had a parent who was diagnosed with colon cancer at 45, you would start getting screened at 35. It can't get more complicated beyond that. So you get screened at 35 and you had polyps. Does your child then need to come in at 25? And it kind of depends on the polyps that are found. We would view high risk polyps, so large polyps or lots of polyps or polyps with certain mutations within them as indicating that your subsequent first degree relatives need to be screened sooner. So you kind of get into the weeds there, and it often is worth a conversation with your doctor in those situations. If you have a first degree relative who is over the age of 60, so you're like, oh, my dad had colon cancer and he was 75, your risk is a fair amount lower because he was at an older age and more likely to be sporadic. But then we do say come in at age 40. If it's normal, you come back in 10 years. But we do say to come in a little bit earlier in that scenario.
Okay. Thank you very much for your time and all the information tonight, Dr. Susnow.